Welcome to Emergency Office Hours. My name is Danny, and today I wanted to talk about burn injuries. Before I get into it, don't forget to check out our official website, TikTok, and Instagram accounts for more learning resources. Let's get started. Burn injuries occur when the skin comes into contact with heat. Because heat always moves from the gradient of most hot to least hot, that thermal energy will continue to move through the uppermost layers of skin and inward, causing progressive degrees of injury. Burn injuries can be so severe that they destroy the skin, blood vessels, nerves, adipose, musculature, and even bone. Sources of burn injuries can include direct and indirect contact with fire, hot objects, steam, chemicals, electricity, radiation, and even extreme cold. For the purposes of today's video, we're going to focus on thermal burns from fire and hot objects. When caring for a burn patient, it is important to assess the degree of injury. Based on how far the burn has progressed inward, we can assign a numerical value to that burn. Here we have a cross-section showing the typical anatomy of human skin. From top to bottom, you can observe the epidermis, dermis, subcutaneous fat layer, and musculature. Underneath all of this are your bones and organs. When this cross-section of skin is exposed to fire or a hot object, the burn injury will move inward through each layer of the skin until the thermal exposure is interrupted. When the burn injury stops at the first layer, the epidermis, this is referred to as a first-degree burn. This is a superficial burn that leaves the skin red and painful but does not break the skin. When the burn injury passes through the epidermis and into the dermis, this is a second-degree burn. Second-degree burns are partial thickness burns that leave the skin red and weepy with blisters. These tend to be more painful than first-degree burns. When the burn injury passes through the epidermis, dermis, and into the subcutaneous tissue and musculature, this is referred to as a third-degree burn. Third-degree burns are full-thickness burns and appear as blackened, dry tissue. Because these burns tend to destroy nerves in the area, they are often less painful and described as a pressure-like sensation. Lastly, when the burn passes through every layer of the skin, through the subcutaneous tissues and musculature, and reveals bone or organ tissue, this is referred to as a fourth-degree burn. These burns will present as charred tissue and are the most severe, life-threatening type. After the degree of burn is determined, it is also important to determine the percent of body surface area involved. When estimating this, it is helpful to use the rule of nines. Here we have a human body. Each of the following will account for 9% of the whole body. We have the head, chest, abdomen, upper back, lower back, right arm, left arm, anterior right leg, posterior right leg, anterior left leg, and posterior left leg. Additionally, we have the groin, which is estimated at 1%. The sum of each of these will total 100%, making the whole body. If we have a burn that involves the entire right arm and chest, the total body surface area is 18%. That is 9% for the arm plus 9% for the chest. If we have a burn that completely involves both legs and the groin, the total body surface area is 37%. That is 9% for the anterior right leg, plus 9% for the posterior right leg, plus 9% for the anterior left leg, plus 9% for the posterior left leg, plus 1% for the groin. Calculating the percent of body surface area involved is important because it helps guide our intervention. With burn injuries, one of our main concerns is fluid volume deficit. Fluid volume loss occurs to the body initiating an inflammatory cascade in response to the burn. The capillaries become leaky and our fluid volume shifts from the intravascular space to the extravascular spaces. As a result, our preload and cardiac output drop, leading to hypoperfusion. This hypoperfusion is managed through the use of the Parkland formula. The Parkland formula is indicated in critically ill burn patients who cannot safely manage PO intake. It uses the multiplied total of 4 milliliters times percent of body surface area involved times weight in kilograms to determine how much crystalloids should be administered in the first 24 hours. Half of this volume should be given in the first 8 hours and the other half in the next 16 hours. In addition to fluid volume deficit, we have some other things to consider. The skin is crucial in providing a barrier against infectious organisms and allowing for thermoregulation. When the skin is burned, we encounter risk for infection and hypothermia. Antibiotics and warming measures may be employed to improve patient outcomes. Additionally, pain control with medications like fentanyl can provide relief to patients with reports of intense pain. Thanks for watching. Don't forget to check out the official Emergency Office Hours website and social media accounts. And if you found this video on burn injuries helpful, tune in again next time for more Emergency Office Hours.